Welcome to the Link Podcast. Today we are honored to have a distinguished guest who has made an extraordinary impact on family medicine, medical education, and healthcare transformation. Dr. Ted Epperly is the president and CEO of Full Circle Health, a leading federally qualified teaching health center that operates 9 clinics, 4 family medicine residency programs, and 5 fellowships. With a career spanning decades, his contributions to medicine, education, and policy have been nothing short of remarkable. Dr. Epperly's journey began with an undergraduate degree in biology and anthropology from Utah State University, followed by his medical degree from the University of Washington School of Medicine. After completing his residency at Madigan Army Medical Center, he dedicated 21 years of service in the United States Army, retiring as a colonel in 2001. Beyond his clinical and leadership roles, Dr. Epperly has shaped the future of medical training as a past president and board chair of the American Academy of Family Physicians and a former member of the ACGME Board of Directors. Currently, he serves as vice chair of the ACGME Policy Committee and co-chair of Idaho's Healthcare Transformation Council, leading efforts to improve healthcare statewide. A passionate advocate for family medicine, education, and rural healthcare, Dr. Epperly has authored over 50 publications and the award-winning book Fractured: America's Broken Healthcare System and What Must Be Done to Heal It. When he's not shaping the future of healthcare, you might find him he's not skiing, fly fishing, or collecting sports memorabilia. On a personal note, today's conversation is particularly special because our company's founder, Joel, has had the privilege of working with Dr. Epperly for over 19 years. His insights, experience, and leadership are invaluable, and we are thrilled to have him join us here today. Dr. Epperly, welcome to the Link Podcast.
Thank you, Karen and Joel. Great to be with you.
We'll jump right in. We got a lot of questions, and the concern is the reality will probably be we'll have more questions than we have time. We could probably have 2 or 3 hours and still not have enough time. So I'll jump right in. And thank you for taking the time today. We really appreciate it. We know you're very busy. You're the CEO of a big organization, which has grown dramatically in the last 15, 20 years. You are greatly involved in family medicine and residency training. Give us a couple of the highlights or some of the highlights after you come to Full Circle.
Thank you, Joel. As Karen noted, I spent 21 years in the United States military. I was a family doctor in the military, and I learned a lot. What it taught me that I didn't recognize at the time was that the secret to keeping populations healthy was to focus on primary care and upstream healthcare, meaning good chronic disease management, timely access to appropriate care, preventive aspects of healthcare. So when I transitioned from the Army in 2001 and came back to my native state of Idaho, which I was born and raised in, I recognized how broken the healthcare system was. The military had focused on high quality, timely access, prevention, and health. And what I came to, it could have been anywhere in the U.S. It could have been Seattle. It could have been San Francisco. It could have been Tampa, Florida. It could have been Cincinnati, Ohio, was a very broken healthcare system, one that was focused on making money instead of keeping people healthy, one that was focused on high-end procedures and not upstream basic primary healthcare. And so when I came back to Idaho and became the director and CEO of our system, which focused on education and healthcare, I rapidly recognized that what I could do to make a contribution was to really do what I could to help make healthcare better. My wife, Lindy, really helped me with that, Joel and Karen. I was lamenting to her the state of health in Boise and our area. and it was similar across the nation. And she said to me a very important question. She said, "Ted, so what are you going to do about it?" And I recognized at that moment, not only did I need to be able to verbalize what the issues were, but I needed to sort out what was under my control and what wasn't, and to expand what I could do within my sphere of control. So not only did I attack the problems at a local level, which will lead us to a lot of our next couple questions around community health centers and how they can help solve this problem, but at a larger macro level, I recognized if I was going to do anything, I needed to engage in the politics of healthcare. So because of that, I ran for the board of directors of the American Academy of Family Physicians. That is our membership organization, 150,000 family doctors across the U.S. It had a large footprint in regards to healthcare in this country. Not only did I get elected to be on the board of directors, but 3 years later, I got elected to be the president. And then after that, the chairman of our board. So I had a 6-year run in which I was in key leadership positions. And all of this overlapped the administration of President Obama coming into office. And so I had the opportunity to be a large part of helping form the Affordable Care Act around patient-centered medical homes, timely access to primary care, FQHCs, and their continued build-out and importance, and the development of what was called a teaching health center in the Affordable Care Act, which was a compilation of an FQHC with graduate medical education programs integrated into them. And so I take some moment at the start here to help explain the journey I've been on to try to help transform both only healthcare, but also the graduate medical education footprint. Because if we can train doctors to understand the importance and the value of primary care and upstream healthcare, then I've done my part to help with the question of, so Ted, what are you going to do about it?
Good. Are you on that note? I think when you and I had met, but we landed in Alabama and consulted with Dr. John Waits. And I was doing some research and saw that you had won the Parker J. Palmer Courage to Lead Award in 22, and he won it in 24. And that was a consulting project that we went to together. Are you still, congratulations on that award, by the way. Are you still doing any consulting, or how are you sharing and spreading kind of the knowledge that you have? You started by saying what your wife's question to you is, or was. How are you now taking that beyond your current role internal to the organization? How are you taking that out to the country, or are you?
Yes, Joel, I still am. My sphere of influence has stayed broad. I'm involved, I'll just speak to the state of Idaho first and then to the nation afterwards. At the state level, I'm involved with healthcare transformation for our entire state based on a primary care model, as Karen alluded to in the opening. I'm also the coordinator for our state through the State Board of Education here in Idaho for our graduate medical education programs in the state. So I've been critically involved with both healthcare transformation and GME growth in the state of Idaho, and I'm really happy about that. I made a good choice and a good decision to come back to Idaho because it was a state that needed what I was willing and wanting to offer. At the federal level, I've been on multiple boards. Karen alluded to the Accreditation Council of Graduate Medical Education. That accredits all programs, residency programs in the United States. There are 10,000 GME programs in the United States, and there's 125,000 residents and learners in those systems. So I've been part of accrediting programs for the nation around quality, patient care, communications, professionalism, system-based practice, practice-based learning and improvement. All of those things I've been able to have a part of, and I'm proud of that. I've also been on the Council on Graduate Medical Education, which is a HRSA body, advisory body to Congress, and the Secretary of HHS. So in the COGME role, COGME role, I've been able to help continue to advocate for the importance of rural medicine, rural health, primary care, rural and underserved health and healthcare. So I've been able to do all of those things, which I've been extremely happy with, because it again, it answered that transition itch I had from the military to the civilian sector of what am I going to do to try to help fix a larger system. I've always been a systems level thinker. And so to be able to be a part of the system has been really valuable. And I'll just mention one thing here too, Joel, because you'd mentioned the Parker Palmer Courage to Lead Award, and I was very honored to receive that from the ACGME. It's a distinguished award. But because of all of my work around healthcare transformation and the workforce issues of graduate medical education, et cetera, I just got nominated to be on the National Academy of Medicine. That's a membership, a very prestigious group to be a part of. In medicine, the only thing that's greater than that is to win the Nobel Prize.
Well,
So,
congratulations.
yeah, for a kid from Idaho that had no aspirations of doing anything more than just being the best doctor I could be, to find myself now to being in those circles has been incredibly rewarding. And I'll stop this part with that comment.
All right. Yeah, that's great.
Dr. Epperly, I had a question. You had referenced when you were thinking about what you were going to do and how you were going to make that impact. You said you wanted to focus on your local area and what your sphere of influence was. But then you took it to that next level, that 10x thinking very big. And I know a lot of people now in the industry are struggling with what can they do with all of the challenges, and what would your advice be to them as far as being able to have that 10x thinking and expanding their sphere of influence?
Yeah, it's a great question, Karen. Thank you for that. I think it's all around building relationships and building a team. If you go about your work in a way that inspires others to be a part of a solution and bring ideas to the table, I have found that people will gather around good ideas. And that's in this environment in particular, the right way to go about it, because then it's not a Republican idea or a Democrat idea. It's just a good idea. And I have found that both parties will gather around good ideas because that makes for good policy. So as you get into a 10x thinking mode, as you've described it, building relationships and having good thoughts that are not partisan, I think draws people from both parties and they want to support it. So a perfect example is here in Idaho. When we proposed healthcare transformation around a primary care-based system, and we proposed expanding the GME, graduate medical education workforce, the Republican and Democratic legislators of our state flocked to those ideas because the legislators knew we needed it. And so I think being able to have good ideas in the right time and in a way that builds relationships of trust so that people know that you're not in this for any other reason than trying to do this greater good, if you will, for the people of the state. That's been extremely important. And then the last thing I'll just add, because I mentioned it a little bit earlier, was to build a good team as well. Nobody ever achieves any of these things alone. It's all about having like-minded people that are very supportive and interested in the work, empowering them, encouraging them. In return, they empower and encourage you. So having a great team is a way to really help then amplify that 10x into a group that then amplifies into a larger group. And then all of a sudden, you've got things at a legislative level that's working or at a congressional level that's working. And all of a sudden, even a little kid from Idaho can make a difference.
Great, thank you. Very inspiring.
Yeah, so something I'd noticed over the years of my work was you had a really good relationship with the political side of the state of Idaho, which seems to be lacking in a lot of states. So are you out helping people understand how to build those relationships? Because that what you just said, I think, is absolutely right. And yet there seems to oftentimes be a division or lack of communication. I don't know if you see that. Maybe things have changed, but that was a critical step as I kind of look from the audience of your success. Is you've really done a great job of maintaining, building, establishing kind of cooperative relationships with people at the kind of the congressional or the legislative level.
Yeah, thanks, Joel, for that. I really agree. In Karen's introduction, she'd mentioned I like golf, so I'm going to use a little bit of a golf metaphor here. The way you get good at golf and play a good round of golf is to keep the ball in play. It's to keep it in the middle of the fairway. And what I recognized in trying to help systems improve was that you could not go far left nor go far right in terms of keeping the ball in the middle of the fairway. You had to play the ball down the middle. And so politically, I think that there's a real huge amount of insight to that. You cannot align yourself far left nor far right if you're going to appeal to a broad segment of society. You've got to be able to come up with good ideas that stay in play and do not polarize people. The environment we're in now is hyper-polarized, as we know. And it's been a real challenge to make sure that you keep the ball in play. It's almost like playing on a really windy day. There are wind gusts that are blowing all over the place all the time. And so to keep the ball in play is really, really important. So with that metaphor in mind, Joel, I have been fortunate to have really good relationships with the governors of Idaho and our legislature. And I think by being consistent, by being honest, by being transparent, by being fair, by understanding, by listening, helping be able to get to the middle, by being able to not take sides, but to try to focus on principles, have been incredibly instructive to this journey. And I would just share that with your listeners as well.
Good. Thank you. That's good. So I read an article recently about the 3-year residency requirements for foreign doctors and how Idaho has jumped into that group of states not requiring that. They've changed some of the rules. Can you talk about that a little bit, and how has that affected access to care in rural communities? Idaho has mostly rural communities. Has that had a positive impact? And I'm sure you've been a part of that conversation.
Yep, I've been central in that conversation. It's really only in its infancy in terms of its operationalization. The idea is that If there are well-trained physicians from outside the country that have immigrated to this country, can we put them to work in some way that helps augment the workforce and helps care for people? You have to recognize that Idaho is right at the bottom of the number of physicians per capita, as are many of the Intermountain states, Wyoming, Montana, Alaska, where all four of us are right towards the bottom of the number of physicians per capita. That comes part and parcel, quite frankly, with it's part of the Intermountain West, and there are a lot of small rural places. It's hard to get physicians into these places unless it's in the larger capital cities. It's very hard to recruit physicians. So you've got to train them in these locations to get them to these locations. So with that as an aside, and we'll probably come back to the retention of physicians in states like ours, because there's a lot to be learned from that too. To your question now, Joel, the legislature started to look at, well, are there additional ways then that we can get a physician workforce? And you have to understand that Idaho, Boise, Idaho in particular, is a refugee relocation city for the United States Department of State. So we have a lot of refugees that come to Idaho, especially to the Boise and Twin Falls areas. In fact, just as a quick aside, we have 43 different languages spoken in our clinics right here in Boise, Idaho. 43 different languages. Can you believe that in a place as rural and out of the way as Boise, Idaho is compared to the larger cities of the United States? So the thought is can we take some of these refugee physicians, and we have multiple numbers of those here, and somehow put them to work in some way that's meaningful? So the legislature has been working proactively. I've been a part of that group with others to try to help design a way in which we could augment our workforce. But we're just in the infancy of that. Only a couple of the physicians that are in this category have either gone back into training programs or are even being considered for this. The guts of the program would take a physician that has been graduated from an accredited medical school in their country and have done graduate medical education work and have worked for at least 3 years after their residency, but then got translocated, no fault of theirs, either because of war or strife, civil strife in their country, to the United States. So we looked at those physicians that would fall into a time window where they weren't out of practice for more than 3 years, but had practiced for at least 3 years, and started to pair them up in practices where they could be supervised. We thought it would be a win-win, but we're just in the infancy of this. So Joel, to your question of how are they doing? Are they out in the state? They're only at the very early part of the pipeline of getting into practices and getting supervised so that they can go out and be a part of the solution. So that's kind of a unique approach that Idaho has taken in addition to our graduate medical education to try to help the workforce shortage issue in a state that desperately needs it.
Good. Is the current focus on immigration going to be a struggle?
Yes. In a word, yes. The immigration pipeline is turning off. And part of our clinic system of our 43,000 patients we care for in our 9 clinic spots over the Treasure Valley here in the Boise area have been refugees that come through the State Department. That is going to turn off under the new president and his administration. And so we'll have to pivot with that. It'll stop bringing these potential physicians in as well. So it's just part of the challenge, I think, of the climate we're now in regards to major shifts in populations that will occur around issues like this. None of it's a showstopper, but it does alter, the way that we were going about business. And so I think there's a point for the listeners in that too, and that is that I think to be successful, you must stay flexible and nimble. You can't be so rigid or unable to change directions and pivot that anything that could happen externally stops your operation. So you have to, I think, as a leadership lesson now, stay nimble in the environment you find yourself in. Keep your eyes and ears open. Keep your team thinking, so that as things happen, you don't get into a mode of feeling like you're a victim and complaining about it, but start to pivot into being proactive about it. And what can we do in this environment then to continue things to work? And I'll end with this point back to the question, Joel, of this unique and creative solution to workforce in the state. I think rural states in particular, are particularly adept at thinking out of the box, of being creative, of being innovative. And that's what it takes in environments like we have in the rural West, is you have to be creative and innovative if you're going to get things to work.
So at the federal level, this issue of physician shortages has been coming down the path for a long time. What I recall is one of the issues was that the funding for expanding residency programs was pretty narrow. I mean, it was through hospitals only. Then the teaching health center funding came along, and so that expanded it. But there's a shortage of funding available for residencies to expand, hence a shortage of physicians. Is there any movement on that at the federal level? It just, working in this industry, it seems so evident that, there's got to be some funding or nothing is going to change. And I think, 6-7 years ago, there was a projected, 40, 50,000 physician shortage in 5 or 10 years, which is probably where we're at right now. So has anything happened at the national level around funding for residency programs?
Yeah, it's a really great question, Joel. I'd like to be able to answer that question, that the United States has been very proactive about its workforce thinking, but it hasn't. We've really struggled in this arena. And in fact, the funding for graduate medical education primarily came about when Medicare and Medicaid came about in 1965. I kid you not. That's where the funding started, and it's been minimally changed since 1965. And in fact, in 1997, under the Clinton administration, all funding for graduate medical education got frozen at its current level, and it's not changed since 1997. So the program started in 65, frozen in 1997. And so, as you just pointed out, Joel, because of that, we have a growing, looming crisis of physician shortage because we've not kept up at the federal level for funding. Hence why the Affordable Care Act with the Teaching Health Center GME program became the newest innovation. That was back in 2008 to 2010 when that all came about as a particular way to start to fund federally qualified health centers that were community-based instead of academic teaching medical centers in large cities, to then start training the next iteration of workforce at the community level. That was a major change. But even across the United States to this point in time, there are only 60 to 70 teaching health centers in the United States. And there's no way that all of those places can keep up with this looming workforce crisis. All of that to say that that's led to an enhanced growth of nurse practitioners and PAs. And I want to say that they're absolutely critical to this problem as well. We need them. It's how we work together as an integrated team of physician, of nurse practitioner, of PA, with skilled nurses and medical assistants and social workers and psychologists and pharmacists, that you can start to really care for communities. And so I've been able to help people transform their thinking a little bit about, let's not get into protecting our turf, one each, trying to say that physicians and physicians only should be handling this. We are way past that. This has to be transformed into thinking of how a team handles this problem. And that team looks like this. It's made up of a physician. It's made up of a physician assistant. It's made up of a nurse practitioner. It's made up of skilled nurses and medical assistants. It's made up of a pharmacist, and it's made up of a social worker. And that team can start to really care for a community so that we start to maximize what everybody can do. And that's why this concept of a patient-centered medical home is a team-based way of taking care of people and their families in a community setting becomes really critical. So all of that to say is funding hasn't kept up. It's led to major systems problems downstream that we're now dealing with. And the way to be innovative and creative about that is to change our thinking of about how the team has to work to start to care for people and to keep the community healthy.
Good. One correction. When you had your team-based design laid out, you didn't have the CFO included in that.
Yes. And that is such a good point, because at the end of the day, it's still a business, and you got to keep your doors open or you're not of help to anybody. And so to run the business, I think you've got to have skilled and qualified people that are both at the operations level, the finance level, the quality level. It takes a broader team. I was just, as you guys know, talking about the clinical care aspect of that team, but the team behind the team is critical, and that's finance, that's operations, that's quality, and it takes all of us. It takes a village, if you will. Yeah.
I used to tell CEOs that you think this is all about patient care, but you need to change your perspective. It's all about the bottom line.
Yeah. It's really true, Joel. And let me just make a quick point to that. That's maybe been I've been a physician for 45 years now. And one of the things I've learned the most about all of this is just to that point. And that is that if your financial shop is not in order, if your financial house is not in order, then none of this matters. No margin, no mission. You've got to have a margin to be able to do the things I'm talking about.
Yes, that's probably one of the barriers for rural health. I know there are a lot of contributing factors to physicians moving into rural communities, but as rural providers struggle to provide their care, it isn't just a recruiting issue, it is a financial issue also. How do we survive financially in this little town in Idaho that doesn't have the volumes and because we're still essentially a volume-based provider. It's all about the bottom line, and it's not all about the bottom line, but you have to have a bottom line, and you have to have volume in this, the way our care system is designed, in order to have a bottom line on your financial statement.
It's very true, Joel.
So how is patient-centered medical home care reimbursement strategies in Idaho changing due to the, just kind of a need to provide good quality care and not so much on a volume-based system.
Yeah, it's really an excellent point. So there are two things I'd say to this. The reason primary care training becomes important, especially to rural places, is that those are the types of physicians that can not only exist but thrive in those areas because their skill set is so broad that in one physician you can have somebody that takes care of pregnant patients, little kids, adults, older adults, and everything in between. You can't take a neurosurgeon into a community like that. You can't take a rheumatologist or a neurologist into a community like that. They don't have enough patients they can see. But you can take a family medicine doctor, or you can take an internal medicine doctor into those small communities because they'll have enough patients to care for. So there's a reason that these smaller communities thrive on family medicine or internal medicine. It has to be at a general practice level because they don't have enough patients to support them. Let me give you an example. For a family physician's practice to thrive, that physician has to care for about 2,000 patients. For a neurosurgeon's practice to survive, they have to be caring for about 50 to 100,000 patients. So you're not going to put a neurosurgeon in a small rural community like Arco, Idaho, or Salmon, Idaho, and have that person be able to continue their practice. But you can certainly put a family medicine doctor into those communities and have them practice and survive. Now to the second part of your question, Joel, and that is, how is payment needing to transform? You're exactly right. We're still really stuck in a fee-for-service, volume-driven system. And that's part of the problem, quite frankly, because it incentivizes production. It incentivizes doing things to people. The whole shift in thinking has to be that we keep people healthy. It's not that we keep doing things to them. It's that we need to keep them healthy. Now, just imagine that. If our whole focus were to be to keep people healthy and out of clinics and out of hospitals and out of ERs, and I know for one, I don't want to end up being in a clinic any more than I have to as a patient, let alone an emergency room, let alone a hospital, let alone the operating room. I'd like to avoid all of that. So just imagine that now. If our goal becomes to keep the community healthy so no one's coming into the clinic, what does that do to the bottom line? What does that do to making sure we have revenue and margin to keep the doors open? So as you can imagine, if our shift in thinking is upstream to keep people healthy, then we have to have a backside shift in financing of healthcare. And so the thought being here that it needs to become what's called a blended payment. Some fee for service, yes, but mostly we need to shift into a per member per month capitation sort of system with incentives for quality and incentives around shared savings to keep people out of ERs and out of the hospital if possible. But to have a practice thrive in that environment, you must shift the thinking on how the payment works, primarily towards a capitation model. Now that's created a lot of concern because the system has made a lot of people for money for a lot of time on a fee-for-service basis. And so and I'll just use this as an example and I'll stop with this. Part of the strategy in our thinking in Idaho was to not only shift to a primary care-based system and upstream healthcare, but was to shift the financial models so that we had more capitation in the model. Now, the commercial insurers and Medicaid were in on this, and they've been a part of that solution but it's still a fee-for-service driven model. We've had quality incentives added by Medicaid and by commercial insurance. We've had shared savings as part of the payment mechanisms. But all of that has struggled a bit. It's just, insurers are really good at doing what they do, and that's kind of watching their bottom lines as well. They've been less than progressive in trying to shift large amounts of money to try to do that. So part of the challenge, I think, in healthcare right now is trying to find the right balance of the payment mechanism to, again, align with the incentives of healthcare and prevention and chronic disease management and keeping people healthy and out of the systems. And that is something that we struggle with in the United States. Now, I'll just give one example here and I'll stop. If you get outside of our country, get outside the United States and go to other industrialized countries, they've done a much better job with this than we have in our country. They've changed their payment and health systems. Usually it's either a single payer system or a nationalized health system. Yes, they have to pay more on taxes for that system, but it's taken away all of this incredible churn, if you will, in the financial model of driving what we do in the United States. And so in the United States, it's led to a very disparate healthcare system, the haves and have-nots. Those people with means get the healthcare they need, and those without do not. And that is part of why the United States, being the richest country in the world, still struggles with our healthcare rankings nationally and internationally. The United States is almost at the bottom of every health outcome when you look at a population compared to other countries. And that is a major disconnect. We pay by far more for healthcare in our country, but our outcomes are less. That is the disconnect I'm talking about. It's the disconnect between the operational delivery of healthcare and the payment for healthcare.
That's interesting. I think an example, personal example, is working in the state of Washington. Capitation became fairly common for primary care, but at the state level, the capitated dollars were kind of quantified alone without any specialty or hospital. So rather than the continuum of care saving money, it was about how can we save money at the primary care level, and specialty care, hospital care, pharmaceutical care were carved out of that model. So you're working with a system of family practice that sees a very broad scope of services and probably is really the keeper of the referrals and the keeper of the system in some ways, but yet they had the smallest percentage of the total dollar, healthcare dollar, and there was, because of this segmentation of dollars, there was no ability to make any more, even though their outcome and their service levels and their expectations were broader. They had a limited number of dollars. And I always felt like that's such a short-term kind of small vision of what healthcare really is.
It's very true, Joel. Let me make 2 points on that. Across the nation, about 5 to 6% of the spend on healthcare is to primary care, but 50% of the clinic visits are to primary care physicians or providers. 5% of the spend, 50%. What's wrong with that picture?
Right.
And so if we invested 12% of the spend or 14% of the spend, just imagine, not only would we see a lot more providers in primary care, but we would start to shift the money from the back end of the system towards the front end of the system, towards, again, this creation of health, not treatment of disease. creation of health. And that is the distinction. We've got to move upstream and be proactive, not just wait for disease to happen when it's high cost and reactive. The second point that I wanted to make in addition to that is that is exactly why I went into being a CEO of a federally qualified health center. I could have made more money. I could have made gobs of money, probably being in the private sector and being the CEO of some health system. But that's not where my values were. I wanted to make sure that there was healthcare for all people, especially those without means. And that's what I really loved about the federally qualified health center model, is that we were focusing on those that were underrepresented, that were underserved, those that struggled to find access to health care, those with mental health issues, those with addiction health issues. Those were populations of people that needed our care a lot. And so it resonated with my values to do that. Maybe that was part of what I learned from the military as well, is that we needed to care for people, not special people or certain types of people, but we needed to care for the entire population of people. And that's what resonated with me around FQHCs.
Mm-hmm. Good. Yeah, I appreciate that. That's something very few people, I think, give that consideration. So a few years back, you could see the decisions by medical students to move towards specialty care versus family practice. Dollars were probably dollars, and schedules were maybe the reasons for that. You know, everything's cyclical. Are you finding there are more becoming interested in family practice as
No.
time is going? No.
Sadly not, Joel, for just the reasons you mentioned. Without a change in the payment structure, where the money in medicine is on the back end of the system. It's high cost care, it's procedures, and it's subspecialists. And so even to this day, even with this thinking that we've just shared together for the last 45 minutes, the medical students are voting with their feet, and they're voting towards the back end of the system. It's dollars and it's lifestyle. You work less hard in specialties. You work less hard if you're working in shift care in hospitals. You're working less hard to earn more money in those settings. What the medical students of today are seeing is that it's really hard work to work in primary care. There's burnout, especially as we just went through the pandemic. It's been brutal. And so we're seeing very low numbers of medical students come through the system. Hence why, to your earlier question, Joel, a state like Idaho was looking for all hands on deck in terms of refugee physicians. Could we add those? It's why I also add that nurse practitioners and PAs have to be part of the solution. But what we're seeing with the nurse practitioners and the PAs is the same thing. They're migrating towards the subspecialty end now, not towards primary care, because the money is greater. So it's how we've incentivized healthcare in this country. The model pays more to do things to people. And if that's where the money is, that's where the people are going to go. And it's as simple as that. We've got to change the focus. And that starts a lot with how the money flows. The money flows upstream, the workforce will flow upstream. If the money stays on the back end of the system, that's where the workforce is going to go.
So talk a little bit about the FQHC and maybe your migration into the FQHC world. I think, as we're talking about this, you really see some opportunity in the FQHC world because of the reimbursement methodologies, which add some money based on cost as opposed to just a straight fee for service. But that issue of, I think I heard this I was listening to a presentation by the person that was head of Idaho's Department of Health and Welfare, probably 20 years ago. And the percentages you said of dollars, you were talking visits, but of dollars around the whole healthcare cost to the state, family practice was like 5 or 6, 7%. Then you've got, long-term resident care, pharmaceutical care, hospital care, specialty care, all of those were greater. And there's constant conversation about how do we get cost-based reimbursement for community health centers. And there's always a big battle, a lot of resistance to that. I don't know if that's a lack of understanding at the state level. They're just a business and they're trying to save the bottom line. But I see the community health center system really fitting into kind of that solution. So talk a little bit about, kind of your process and how you went from a residency program, or how you got into the residency program. Is that where you started? Did you start that and move into your FQHC model right now?
Yep, our organization is celebrating its 50th birthday this year in October, and it's been here since 1975. And it started initially as a 501c3 nonprofit residency program. When I got here in 2001, as Karen said, we were not an FQHC. And as I understood what FQHCs were and FQHC lookalikes were, I recognized that our model needed to transform for us to be able to thrive in this environment. 85% of our payer mix were either Medicaid, Medicare, or the uninsured. 85%. And I said, wow, that is not a population that we can easily maintain margin on unless we transform the payment model. Now, fortunately, I learned about FQHCs, and I said, why can't we become one of those? I said, if we can do that, the PPS rate for Medicaid and Medicare will provide us the margin we need then to be able to grow. And so, Joel, that's when I learned about you, and in 2006 engaged you to help us with that transformation. And so in 2007, we became a federally qualified health center lookalike. We started to get PPS rate enhancements around Medicaid and Medicare. Because of that, in our journey forward, we became a federally qualified health center teaching health center in 2011. We were one of the first 11 in the United States to gain that designation. And in 2013, we then transformed our entire system to be a federally qualified health center. And so, and then we received the Section 330 grant along with that, as well as Federal Tort Claims Act protections. So all of this has been an incredibly valuable and important journey, all starting with us providing primary care to underserved people. And how could we control what was within our sphere of influence? Back to the earlier point I was making about what can we do to try to solve the problem. We transformed our finance model along that of a federally qualified health center. I will tell you categorically, that's the most important thing that's ever happened to this program. In its 50-year history, the most important thing that happened in our entire history was to become a federally qualified health center, because that then gave us the margin to be able to grow. So we've now grown from one program to 16 different educational programs.
Oh, that's great.
We've grown now from a $2.5 million budget a year to a $66 million budget a year. We've grown from 31 employees to 500 employees. We've grown from one clinic to 10 clinics. We've grown our footprint and our ability to make contributions people's care and lives in ways that have become incredibly important. So it all ties together with what we talked about right from the get-go. And that is, can you verbalize what the problems are? If so, then what can you start to do about it? What's within your control, what's not? And then to amplify that sphere of influence in a way, as you said, Karen, to 10x thinking, so that you can start to see what the impacts can be that you can start to shape. And that's been our journey here, and it's been incredibly purposeful, and it's been incredibly meaningful.
Yeah, you mentioned the word purposeful, and I would like to say the growth you've had isn't for the purposes of the bottom line or for big size. It's quality of care to a population that needs access to care. So congratulations on that. You've done a great job of leading that forward.
Oh, thank you.
Yeah. Yep. One
And
question I had in regards to a question that came up a lot when I was working with these grassroots entities is, does a federal overlay result in micromanagement that we're going to have to struggle with and we'd rather not, so let's not become an FQHC?
just the opposite for me. Um, it's not been micromanaging at all. It's been guideline setting so that it's helped us know what the requirements from the federal government are that we need to meet. The 21 program requirements, having our governance in order, having our quality metrics and our operational metrics that we report has helped us focus on what the federal government requires for this partnership with us, if you will. And remember, I came from the military. 21 years, I've worked with the federal government. I knew how the military operated. I knew how the federal government operated. So for me, it wasn't a leap of faith to feel like this was a partnership, not a micromanagement or a thumb on me, as much as a partnership with me. And I think having that mentality has been really helpful to me because I've never seen it as something that's been onerous, as much as it's been something that's been helpful, and it's proven that to be that way. I think it gets to a point, and I can end with this, is that if you keep your mind open and a positive attitude, things are going to happen, and things that are good are going to happen. If your mindset is negative and cynical and oppressive, then it's not going to take long for that to happen. And so we all have a choice in terms of how we're going to approach solutions, and that's been mine.
Good. Good. That's a good takeaway for any system, regardless of healthcare. I've got a few in mind right now I'm going to share this podcast with so they can hear you talking about being positive versus being negative, because that's a really good point.
Yeah.
So one question, this is an aside kind of out of the realm of our conversation, but did the quality metrics, kind of the comprehensive care systems come from the military? Is that where the feds got their idea for the community health center model, or were you kind of learning the quality side of this industry at the time you became kind of an FQHC?
Yeah, it's a great question, Joel. I never really contemplated, was there a connection between the military and FQHCs in some way? I think in many ways they were in parallel universes. The HRSA side of the house was trying to figure out how best to care for communities back to the 60s, late 60s, middle to late 60s for FQHCs in terms of kind of when that movement started. The military has always been pretty upstream around quality and trying to keep populations healthy. And so I never recognized maybe the parallels until I again got out and then recognized how dysfunctional the system, the civilian system was. And I never put this together until you just asked that. Maybe it was my way to get back to a federal system, if you will, that could make this work in some way that made sense. And maybe that's the bridge that I was able to cross, was to take what I'd learned in the federal system and the military and apply it to a local civilian setting through a federally qualified health center to start to get the two to work together.
Do you have a opportunity for continued growth at Full Circle?
Yes, oh yes, and plan to. On the education side, we want to grow more rural programs, family medicine training programs, put them out into rural sectors. We started a pediatric residency. I'd like to start a surgical residency here in our area. We do not have a general surgical residency program in the state of Idaho. The closest to us is in Seattle, in Salt Lake, and in Portland. Those are all long distances away from Boise. So I'd like to grow the educational footprint, more family medicine, general surgery, in particular. On the clinic side, would also like to grow our footprint in terms of the clinical population. Boise, Idaho, right now, the Treasure Valley is about 700,000 people. It's projected to be at 1 million in 2030. I mean, that is rapid growth.
Wow.
We have 200,000 patients here right now that are at less than 200% of the federal poverty level. They need care that FQHCs can provide. And in our neck of the woods, we have a wonderful sister FQHC, Terry Riley, in the Nampa area, and we have ours, Full Circle Health, in the Boise area. We both have clinics in each other's areas because there's enough need. Between the two of us, we're only caring for about 80,000 patients. There's 200,000 patients that could utilize our services. So as you can see, there's a lot of work yet to be done. And so we want to grow and expand the footprint, both in terms of the clinical side, but on the education side too. And I'll end with this, Joel, is not only are we educating excellent physicians to go out and be part of the solution, but we're training them how to work in this model so that they can go out and help be parts of FQHCs in the clinical futures. Now, that doesn't mean that they can't go in other hospital systems or other private clinic systems. They can go wherever they want. But what we're finding is that if they've trained in this setting, then they're more likely than not to continue in this setting. And we've given them really marvelous opportunities to see how it works so that we can help populate FQHCs in our region and across the United States as well.
Good. I remember a presentation when I was in Boise, and you noted the number or the percentage of residents that stay within Idaho. Do you remember? Do you know what that number is now?
Yeah. So we've had 500 graduates from our program, and we've been able to keep 54% of them in Idaho, and just right at 40% of those into rural or underserved areas of Idaho. And if you take the 6 states that touch Idaho, Washington, Oregon, Nevada, Utah, Wyoming, and Montana, 83% of our graduates are either in Idaho or touch states that or in states that touch Idaho. That is an incredible shot pattern in terms of keeping people either in the state that needs them or in surrounding states that need them as well. So we're really proud of that shot pattern.
Yeah,
And
that's amazing. Do you
yeah,
is that normal for residencies trying to train or training for rural communities, or are you exceptional in that regard?
we're exceptional in that regard. We are in the top 5 in the United States for retention in the state of training. And we're really, really, really proud of that. And we're also in Idaho, the third fastest growing GME producing state in the United States per capita. So we've got in front of this issue. It's going to take years to solve, of course, but we've been able to start to make some differences in that. And again, back to the issue earlier of systems thinking, and my wife's question is, so what are you going to do about it? These are things now amplified over 25 years of being here that we've been able to do to start to answer those calls and those challenges. And I'm particularly proud of the fact that that the team here at Full Circle Health has stepped up to the plate to try to help solve these issues. And at the bigger sense, that'll be the most important work we've done.
Mm-hmm. Good. Now, are you providing dental care?
No, what we opted to do with dental. So we focused on primary care, behavioral health care, and pharmacy, and graduate medical education and other health learner education. We have residencies in pharmacy and social work as well. So we replaced dental with graduate medical education and other health education programs. What we did with dental was really important, though. We contracted that out to our sister FQHC, Terry Riley, so that we refer our dental patients to Terry Riley. So it's been a win-win. They've valued and gained from that. Our patients are well served by that. We can get them in a very timely way. And so it's a way for two separate FQHCs to work together. We've shared dental with them. And of course, then we, on the hospital side, we care for many of their patients to get into, that need admitted to the hospitals, because our residents, part of their training is in the hospitals. So we're replete at all the hospital sites in terms of the training model. So Terry Riley refers their patients to us in the hospital settings. We refer our patients to them for dental work. And it's been a way to take two separate FQHCs and have a share together, a Venn diagram, if you will, that overlaps. And it's been very helpful.
Oh, good, good. This is a step back a little bit in our conversation, but the hospital gave Full Circle a fairly significant grant every year as a part of that training cost. Is that still something that you receive from them, and how do you maintain that relationship in that regard? Because that, the hospital's giving up the funding for you to do some of that work I think it's a unique situation or a unique design.
Yeah, we've been very proud of our two hospitals, St. Luke's and St. Alphonsus here in Boise. Both received Medicare GME dollars. This is back to the 1965 model of Medicare GME that was capped in 1997. So for the number of full-time equivalent residents we have training in their hospitals at any one time, the federal government gives them an amount of money for graduate medical education training. That's part of the 1965 Medicare model. And what they do is they turn around and pass that money back to us that they get from the federal government, dollar for dollar. They just say, hey, your residents are in our hospital. They're helping care for the patients in our hospital. They're doing a great job. We will give you every dollar that we get from Medicare around this GME funding. There's a direct and indirect component of that. And we'll pass that back to you. And that's been very helpful to us. All of our GME funding streams, be it through Medicare, be it through Teaching Health Center, be it through the state, because the state has supported our residency training as well for all residents in the state of Idaho. I'm proud that we have a state that has stepped up to seeing the need and funding that. But all of that together, Joel, all the GME money, if you will, is only 16% of our revenue stream. So 84% of our revenue stream is coming from outside of medical education. It's coming through patient care. It's coming through pharmacy. It's coming through other grants and services we provide in the community. So I'm glad to be able to mention that. But yes, you can't do this without hospitals being also part of the community and part of the solution. It's again back to that. If you're going to build a village in a residency program and a learning institution is a village, you've got to have community partners and stakeholders that are going to step up to the plate and support you. And I'm really proud of our two hospital systems. They've been staunch supporters for 50 years now.
Yeah, good. Well, we've been on the call now for an hour and almost 15 minutes, so you probably have other things to do. I think we could sit here and talk for a number of hours, but yeah, you probably have other things to do.
Well, it's been delightful, and I would be more than happy and honored to come back at any time and talk further on other topics. As you can see, I can talk for a long time.
Well, there are so many, so many silos in this industry: finance, continuity of care, the whole spectrum of healthcare. We could, your history. We didn't really get into your role as a CEO, which would be an interesting conversation also. So thank you for taking the time. It's been very nice. A lot of fun. Thanks, Dr. Epperly.
Yes,
Oh, it's my honor, Joel and Kara. Thank you too. And I'm would be honored to come back at any time in the future if you'd like me.
Okay. Thanks so much.
Well, thank you very much.
Bye.
Have a good day.